The cost to charge ratio is a fundamental metric within healthcare. And if you are in healthcare, you have at least a top line understanding of what cost to charge ratios are. If you're not in healthcare, you may not even be familiar with the way that cost to charge ratios impact what you actually pay for your healthcare services or procedures. And so in this analysis, I'm going to give you a deeper understanding of what cost to charge ratios mean at a total US level, but then we'll be able to dig down to the hospital level from this data. This data is coming from CMS.gov, and it provides over 4,500 hospital data sets on hospital finances, cost to charge ratios, patient operating expenses, and much more data. And so this is going to be a foundational analysis that I'm going to provide you on cost to charge ratios, and we're going to build on this in very interesting ways that I think you will get a lot of insights from. And so without further ado, let's get started with this analysis. If you want this analysis and want access to it, go to argosanalytics.com/reporting, and you can find this specific analysis under Hospital Cost Dashboard. I will also list the link to this in the video below so that you can go directly to it and then explore the data source if you want to see the actual data where this dashboard is coming from. So let's get started. Cost to charge ratios are interesting in the fact that they provide an overall understanding of healthcare and a specific hospital or clinic or system. And so the costs in this case are operating costs. So these are the operating costs that a healthcare organization incurs in order to provide a service, procedure, or anything else. The charges, on the other hand, are the top line charges that are provided before any negotiation or payment takes place. And so the charges in this case are more in line with your charge master rate, which are your top line charges that are then provided to an insurance company or a government entity before they're negotiated down to what is actually going to be paid by the insurance company, by the patient, and by a government, or paid out of pocket. And so once you understand these two things, then you can start to then understand what cost to charge ratios mean in terms of what you can expect to pay and how you can negotiate down from what you are charging and what that floor is based on their actual costs. Firstly, one of the things that we want to know is what is the hospital charges and operating expenses in a long-term trend. So as we can see in 2011, essentially over all the main hospital systems, the total charges were $2 trillion and operating expenses were $700 billion. And so in this case, it was almost the hospital charges to expenses. Hospital charges were almost 3 times more than the operating expenses. Now today in 2022, which is the latest data, our hospital charges are 4.6 trillion and our operating expenses are at 1.2 trillion dollars. And so what this means is that now your charges at the top line rate are being charged more than 4 times the amount of your operating expenses for that healthcare organization. This doesn't necessarily mean that insurance companies and individuals and governments are paying 4 times more, but this is the top line charge before any negotiation or discount is provided. And so this is important to note because there's a reason why charges are going up while operating expenses are trending upward in a more regular fashion. We can also see this by state and understand that there are specific states that are within the trend of the cost to charge ratio on this plot below, and there are some that are way outside the cost to charge ratio trend. So for example, New Jersey has a lot higher hospital charge to operating expenses, to where you can see some are more in line here. For example, North Carolina is more in line with all the states in the trend. Also, like Washington, D.C., charges a lot, but also has high expenses. And so it is also high, but within that trend of your cost to charge ratio. down below here you have a state like Maryland, to where they have high operating expenses but lower charges, and so your cost to charge ratio would be different in that sense, meaning that they don't charge a lot and their operating expenses are higher, and so they essentially are more in line to what they're charging. And so if any hospital system in Maryland would give you a charge, then it's more likely to be what their expenses are. On the other hand, if you have a state like New Jersey, then what that means is that they're charging a lot, and their operating expenses are certainly high, but not as high as they could be for what they're charging. It's hard to understand here, but once you understand it on a state level, it's a little bit different, and you can kind of understand what cost to charge ratios mean. And so when you look at cost to charge ratios as a state, these look a little bit different. If you're looking at a state like Maryland, or Montana, excuse me, then Montana has a cost to charge ratio of 0.77. What this means is that your costs are 77% of what your operating expenses are. And so in this case, if Montana hospital systems and clinics have a 0.77 cost to charge ratio, what this means is that their costs and charges are pretty close to the same. And so if you get a bill and a top line charge from any place in Montana, they're not necessarily going to come down that much because it's more in line with what their costs are. On the other hand, if you go all the way to a state like New Jersey, then their cost to charge ratio is 1 to where you have 80% there that can come down from what their cost is to what their charge is. So if your cost is high to what you're charging, then you're more in line with what is actually going on, and you don't have a lot of wiggle room. If your cost to charge ratio is really low, like in this specific instance, then your cost is 18% of what you are charging. And so if I were in New Jersey, I would negotiate every single bill I had downward, because I know they can come down at least 50%. If I was someone who lived in Montana, for example, like Cheyenne, Montana, or whatever, Cheyenne, which if you haven't been to Montana, I highly recommend it. But those folks in Montana, the bill that you receive is essentially the one that you're going to pay, because the hospital system and or the clinic can't come down that much. You can see this in the state map below, where the states that are highlighted blue have a higher cost to charge ratio, which means that these states like Montana, North Dakota, South Dakota, Nebraska, they essentially are set up in a way where what you see is what you get. If you get a specific price, you can negotiate it down a little bit, but there's not much more room to negotiate. On the other hand, if you live in a state like Arizona, then your cost to charge ratio is 0.24, meaning that you can negotiate at least down 50%, or at least try to, in order to be more in line with what their operating costs are. If we look at it on a detail level by state, this is what it looks like on a state basis and overall. And so you can start to understand the trend being very interesting when you look at your cost to charge ratio and your operating profit from 2011 to 2022. I will note one of the more interesting things is 2020 was an anomaly, to where your cost to charge ratio came up from its downward trend to 0.38, and your operating profits essentially plummeted from their previous high in total of 194 billion all the way down to 148. So all this to say is that you had a convergence here to where your operating profits came down and your cost to charge ratios went up, meaning that your costs went down and your profits went, or said another way, your costs went up and your profits went down. And so if your costs go up and your profits go down, that leaves less margin for you to operate as a hospital system or a clinic. And then in 2021 and 2022, it bounced back up to its normal trend, which I find very, very interesting. And so if you find a downward trend to cost to charge ratio, it means that you're charging a lot more. And so the charges are getting higher and higher. And the same in this case, your operating profits are going up, or at least trending upward. Now, this doesn't include and take into account inflation, which we could do in the future, which is also in a previous analysis, but essentially operating profits are essentially trying to keep up with inflation and population needs. One of the other things I found interesting is that essentially from 2011 all the way to 2022, your cost to charge ratios are essentially right on a trend where you can almost expect your cost to charge ratio to be essentially at this point or deviating from this point all the way into the future. And so your cost to charge ratios really aren't changing that much over a long-term trend. And so if you expect, for example, your hospital charges to go up, then you expect by that same degree for your operating expenses to go up at that same trend line over time. Really, since 2010 to today, we're really seeing our cost to charge ratio go from 0.41 all the way down to 0.37. So you say, okay, that's a big change, but really 0.41 to 0.37 is high, and it's trending downward, but not trending downward that quickly. And so over the years, you may see this line flatten out a little bit or get steeper, but you're going to see it every year be in line with these cost to charge ratios over time. And it's almost like clockwork once you understand what to look for. And so within your organization, I would ask you, okay, what are your finances looking like? And what is your cost to charge ratio? And is it in line on a long-term trend with this kind of median trend, or does it deviate a lot? And if it deviates a lot, there's a lot of things that can go into that, like your revenue cycle, how you are improving on your AR and accounts receivable, what you're getting paid by Medicare and Medicaid, etc. But if you have a long-term trend that looks very seamless like this, then you can know what to expect in the future based on inflation and based on your operating costs in the future. The other thing I wanted to know was, what is your cost to charge ratio in critical access hospitals versus short term? And so hospitals will essentially charge what their expenses are. And so in this case, any hospital you go to, their charges versus what their expenses are is going to be more in line than your short-term care. Short-term care, in this case, has to charge a lot more for what their expenses are for a lot of reasons. Partially because they're doing specialized kind of care or specialized procedures that require higher charges to then get negotiated down. And so these are your surgery centers, these are your short-term care, these may be your ER facilities, etc., which are charging a lot, but then having to negotiate downward based on requirements from the government or from entities that way. Hospital systems essentially aren't negotiating down, but they have higher volumes. And so even though it doesn't look like there's a big difference between your cost to charges, in this case they're incurring so much volume and serving so many patients that this 40% margin between your costs and charges makes a big difference, because they are serving so many patients on a day in and day out basis that they have to be more in line, and their processes are more streamlined than your short-term facilities. Another thing I found interesting was that the kind of entity matters a lot. So if you're a government, nonprofit, or for-profit, your cost to charge ratios also vary. And so if you're a governmental entity, your cost to charge ratios are higher, meaning that there's not much room to negotiate down. Said another way, whatever your government entity or government facility says is what more or less they're going to charge you, and there's not going to be a lot of wiggle room. Partially because governmental entities have a process that is more stringent or less flexible, and they have a lot of patients coming in the door through Medicare, Medicaid, etc., or they are specifically dedicated to government paid services, to where essentially it's a streamlined process, and these are known procedures, and this is how much government entities are going to pay, and they're not going to budge. Nonprofits, on the other hand, have a cost to charge ratio of 0.37, and so for every dollar that they're charging, their operating profit is 0.37. And so for not-for-profits, there is more room to negotiate downward, and there's more differences in the kinds of services, and there's more potential for high-end services to be provided where there's negotiation. And so that's where nonprofits, they specialize in specific procedures or specific kinds of healthcare that allow them to charge more, and so that's why their cost to charge ratios are lower. Now, for-profit entities have an even lower cost to charge ratio than governments and non-for-profits, and there are various reasons for it, but usually non-for-profits, because they are smaller, or for-profits, because they are smaller, they usually try to give to charge the most they can absolutely charge, and then negotiate downward as much as they can. And so that negotiation, if you're in a organization or you're being served by an organization that's a for-profit organization, then that negotiation is a lot more important than if you're in a government and then if you're in a government facility or not-for-profit. Now, your cost to charge ratio by system also matters, because if you have a system and then you have multiple hospitals in that system, it matters a lot. And different systems have different cost to charge ratios depending on their different arrangements with the government entities, with other hospitals or other entities, etc. And so these things matter when you're talking about systems. To give you an example, in the city that my wife and I live in, we were choosing the kind of insurance that we were choosing based on the healthcare system that they were provided. Essentially, in our town, there's only 2 main systems, maybe 3, but the 2 main systems essentially divide the choices between the 2. And so if you choose one specific insurance company, then they go with one provider and or one system. And then if you choose another insurance company, then they go with the other provider. And so you essentially want to line up and you want to choose the specific system based on what you want your insurance to be, but also what kind of services you need healthcare wise. And so if you are trying to choose a specific healthcare system and subsequently trying to choose an insurance company to use that can be within a network of providers, then this is where it matters, where your cost to charge ratios actually matter. And so if you're in California, for example, then Kaiser Permanente is most likely going to be your largest system. Likewise, University of California, Dignity Health, and Providence are also your top. These are your top 4 healthcare systems that you're going to choose. And so within your city or specific area, these are the top 4, and then you subsequently need to use a specific insurance company that will then be able to be within these systems. And so if you say, okay, well, University of California, the hospital that we want to use is really local and they're very, very good, and so we will then use the insurance company that uses University of California Health, and this is their cost to charge ratio. So I know that our insurance company needs to negotiate down or etc. And so, for example, within California, the highest cost to charge ratio is LA County Department of Health, meaning that they are essentially their costs and charges are very, very much in line. And so if you get any services done at LA County Department of Health, which are very basic services, then you know that whatever bill you get, you should just pay it because there's not any negotiating really to be had here. Now, on the other hand, if you use something like KLK Community Healthcare, or let's choose another one, a lot of these like Dignity Health, for example, there's a lot of negotiating room downward to where you can negotiate, or your insurance company can negotiate downward the top line charge that they're getting in order for you to make a payment. The same goes on this line here. And so if you are looking at cost of charges by state, then specific systems and hospitals will charge a lot more. And so then you can, on a plot basis, you can kind of see the outliers and where the outliers are and what hospital systems have higher cost of charge ratios than others. And so within California, for example, the hospital that charges the most and has the highest operating expenses is Stanford Healthcare, which is Stanford Health. And so if you ever go to Stanford Health, it should be something that is very highly specialized, which is most likely the case. These are your top of the line doctors, you know, the top, most experienced, best healthcare you could get in California is here. But they're also charging a lot and their operating expenses are also very high. Likewise, if you want to look at, let's say, a specific city within California, you could look at, Los Angeles, for example, or you can look at LA as far as a city is concerned. And you can if you live within LA, then you can your cost to charge ratios for Success Healthcare versus MLK is quite different. And so MLK, you would want to negotiate downward a lot more than Success Healthcare, although for these two you would want to negotiate a lot. Also, if you see this trend, you can also identify that Cedars-Sinai Health is certainly outside of that trend line. And so you would want to know that their charge is a lot higher than their operating expenses, but both are higher within this trend for LA. I like to also look at Texas because it's also a very prominent place for healthcare, especially Houston. And so if I look at Texas, for example, and I'm looking for specialized care within Houston, which is spelled various different ways in this data set. But if I look at Houston, for example, then really these are your choices within Houston. You're looking at Memorial, Houston Methodist, you're looking at the UT system, and you're looking at all these small ones. And so if I were in Houston, these are the three healthcare organizations or healthcare systems that I would be going for essentially. And then within that, you could identify, okay, Memorial Hermann is essentially using Memorial Hermann system, and then these are the hospitals within that system. And so if you need very, very specialized care, then you would go to Memorial Hermann Texas Medical. Whereas then at the bottom here, if you're looking at, let's say, the orthopedic surgery, then it's a lot higher. What I will note about Texas versus California is that the cost to charge ratio trend is a lot steeper than California. California's cost to charge ratio is a lot, at least LA, is not as steep as it is in Texas. What this means is that if you have a steeper line, then you have more charges to what your costs are. And so in Texas, and specifically Houston, I would want to have higher negotiating power in order to negotiate downward versus if I lived in LA to where that trend isn't as steep. And so these are things that you may want to take into account if you're looking for a specific city to have healthcare services done, or just understand what healthcare costs are versus what their charges are. So I found this very, very insightful because if I look at any of the main cities, then I could easily understand what my healthcare systems are, which ones are in trend and out of trend, and why is that the case. And so, for example, if I'm looking at Houston again, then Anderson Cancer Center has very, very high operating expenses, but not as high in charges. And so in this case, their cost to charge ratio will be more in line, even though it's a cancer center where they have very, very high operating expenses and their charges are more in line with what these other healthcare organizations are. And so I would try to check the quality of these here if I had specific procedures or needed specific services, but I could compare these and know, okay, this cancer center has higher operating expenses than charges, and so I could actually dig into the finances and their reporting financially to understand why is this the case. Is it because they have more beds? Is it because they have higher operating expenses as far as capital expenditures, etc., and dig into the details. And so this is why cost to charge ratios are important, is because you can understand, hey, this specific hospital here of Anderson Cancer Center has higher expenses than their charges, and then why is this the case? Is it because they have higher FTEs? Is it because their labor is high? Is it because of their capital expenditures? And then you can dig into the finances that they provided to CMS.gov to understand why this is the case. And then if you are a comparable healthcare system or clinic, then you can understand where you lie in the mix and what this mix is and how you can improve your financial situation as an organization based on your competition locally or otherwise. So I found this data very, very interesting because it provides a lot of insights just based on cost to charge ratios across the United States. Again, if I was looking at Texas, I would look at Tenet Healthcare, I'd look at Baylor, Houston Methodist, and these here. University of Texas, in this case, is big, but not necessarily as big. I could also look at it by year, and so if I wanted to look at, let's say, this year, then this year provides a different story than the long-term 10-year trend. Again, overall in Texas, for example, you have Anderson Cancer Center that is a huge outlier when it comes to operating expenses versus hospital charges. And so this is one that I would want to look deeper into within Texas. Again, if you're looking at, let's say, having higher charges than expenses, then HCA Healthcare for Methodist Hospital has higher charges to expenses, and I would then dig into why do they have higher charges than what is the normal trend. Another state we can look at is New York, right? And so if we look at New York is also one of the largest states. And so if we look at New York, we can also understand that it's really the trend is more in line with California. So the cost of charges are not as steep as it is in Texas. And so if you look at Texas, the line is more like this. In New York and California, the line is less steep. You can also look at specific cities within New York, but generally within the state of New York, it's more in line with what California has for cost to charges. And so if I look at like, let's say New York City, for example, this is what I'm looking at in New York City. My choices as far as healthcare systems are limited to 1, 2, 3, 4, 5. And then these are essentially the systems I'm looking at and the hospitals. And so if I'm looking at something very, very specialized, I'm going to go to NYU Langone. Apologies if I've mispronounced things. I'm not from New York, so apologies there. Likewise, NY Presbyterian would be another one you would look at for or you would expect to have high or specialized services done here within NY Presbyterian, or down below you would expect very more basic services to be provided here at the very low level or low end, or very common kind of services within New York. So I hope this helps. I hope this helps you kind of understand and dig in within your specific city or state. There's a lot of details here that are quite amazing that is provided by CMS.gov that nobody really looks at. I haven't really seen anybody do any video or analysis on cost to charge ratios within the United States. And so I was happy to get this data because it provides a lot of insights that the common person, even within healthcare, doesn't really know exists. Likewise, at the very end, I created a cost to charge detail where you can go and you can find a specific hospital that you're looking at or specific city or state, and then understand the healthcare system that hospital is in, the ownership type, what their operating profit is, in case you want to know what their specific operating profit is, and kind of get a sense to what their profitability is, their cost to charge ratio, and then charges as percent of cost. And so in this case, your charges as percent of costs are what you're charging over your costs. And so it's the inverse of your cost to charge ratio. And so if your cost to charge ratio is low, then you would expect your charges as a percentage of cost to be the inverse of that, or very high. So to give you an example, in Louisiana, you have a hospital here that has a cost to charge ratio of 0.3. And so your charges as a percentage of costs is 7 times what their costs are. So they're charging 7 times more than what their costs are. Also for AD Hospital East, which is probably a very small organization, you can see it here. So I hope this cost to charge ratio analysis can help you get a better understanding of what healthcare looks like when it comes to cost to charge ratios, and how much negotiating room you have downward, and what the actual costs are for specific healthcare organizations, and what their charges are. What they charge doesn't necessarily mean that this is what they are actually receiving in terms of revenue, but what it means is that this is their top line charge. Likewise, what their operating expenses are may look like they're steady, but they could be affected by a lot of different situations over time. So I hope this analysis helps you. If you have any questions, then you can contact us on our website, and we will answer those questions or comments the same day, because I look at that email. And if you have any other questions about the data source or anything else in terms of the cost to charge ratio, then feel free to contact us. Like I said, below is a link to this specific analysis where you can look into it, as well as a link to the data set that we're using for this dashboard. So thanks for understanding more about cost to charge ratios. And if you are within healthcare, I hope this helps you get a more detailed understanding of what cost to charge ratios imply. And if you are not within healthcare, I hope this helps you illuminate what this means for healthcare and how you can use these numbers to your benefit when you are using